I'll start with presenting the work that is done by the Eurasian Harm Reduction Association on CLM. And before the beginning of the event, we spoke about the resources where you can publish your studies. So let us keep it in English. So it's in harm reduction. There is a separate tab on community-led monitoring. And here you can see the position from the regional networks on community-led monitoring. You can read it. It was prepared last year when all the regional networks agreed on their definition of the CLM. As you know, this topic is very popular at the moment, and unfortunately, there are many things that are involved in that umbrella um, definition. So, sort of to make that more distinct, to separate one thing from the other, we provided this more specific definition, and it includes a lot of things in, like ensuring the sustainability of CLM processes, well, dealing with the conflict of interest, and so on. So also, we have developed the practical handbook on community-led monitoring tools, which covers various methods of studies, not just common ones, the usual ones, but yeah, that's a big handbook, but it contains a lot of useful information, especially if you're planning to conduct a study and you don't know where to start. And there is also the tool that you can choose for yourself. And in CLM community of practice, as far as I know, there are all the records of our webinars, right? Also, mostly we have here publications of studies supported by the EHRA. That's the example of, or rather examples of community-led monitoring studies, and it includes interviews, polls, analysis of the budget cycle, and what else? Analysis of standards. Also, we have a few methodologies, and that includes the methodology for assessment of satisfaction, client satisfaction with OST services. We'll hear more about that today from our colleagues. And also, part of monitoring is documenting the human rights violations. There is a handbook on how to do that. There is a guideline on advocating for the human rights of women who use drugs. That means like right and shadow reports and so on. And at the beginning of this year, we have published this document, which also reflects the topic of today's webinar on the experience of community-led monitoring of opioid agonist treatment programs in the region, following the methodology I have indicated above. Also here, yeah, a couple of years ago, we had some training sessions according to the guidelines I've mentioned before, so you can use the links and watch those training sessions if you wish. And now we're going to speak a little bit about the context of OAT in the ICA region. Altogether, the OST is available in 26 countries of the region. In 3 countries, it's forbidden. It's Russia, Turkmenistan, and Uzbekistan. In prisons, these programs are not as available. They're available only in 20 countries out of 26. The main drug in the region is methadone. Buprenorphine, if available, is mostly not a pure buprenorphine, but in combination with naloxone. It's available in 18 countries. In Slovenia and Ukraine, they have now long-acting buprenorphine. In Bulgaria and Slovakia, there is morphine, and in the Czech Republic, it's also they have the substitution therapy for stimulant users. And in Ukraine, I think they are planning to do the same, but it's has still not been implemented. So availability doesn't mean that those drugs are truly available to everyone. Uh, just 20 something percent our users are covered with the services. In some countries, there are private sites. In Georgia, Romania, Ukraine, in Slovenia, there is a mobile site of OST. I haven't heard about other countries having similar um, service in our region. In Slovenia and Croatia, family doctors provide OST. So it is prescribed again by the ethicologists, psychiatrists, but it is uh, distributed by family doctors. In Romania and Czechia, uh, the OST is provided by the harm reduction organizations. Sometimes that means community organizations too. And in prisons, availability of a program does not mean high coverage because in Georgia, for example, OST is available only for the purposes of detoxification. In Hungary, they sort of have such programs, but in fact, in the whole history of program, they had only one client. So their colleagues from Hungary, despite formal existence of the program, we should not indicate Hungary as a country where the OST is provided in prisons, because it actually is not provided. And in some countries like Serbia, people can only continue the OST which they had started before getting to prison. They cannot start OST in prison. The biggest problems in the region, the biggest barriers are geographical uh, accessibility. Their programs are only in the cities, if any. There is problem with takeaway drugs in many countries. They are not given, and in some countries, the guidelines allow using takeaway drugs, but in fact, they don't do that. There are problems with working hours. Quite often, we know that the program starts working at 8 o'clock in the morning and at 1 p.m. And if a person needs to go there daily and the site has 1,500 clients a day, that's a very strict limitation of access. There is also the drug user registration. So if it's a state-supported program, they need to get registered with the state authorities, and that really limits the rights of the people. And people start avoiding that. They opt for private sites. And if they can get the OST at a private site, they would do that rather if they can afford that, because they don't have to get registered with the state then. Also, there is a problem of parallel use of street drugs. That's another criterion for exclusion from the program, despite the recent recommendations, and not just recent recommendations, guidelines from the WHO and UNODC on how to organize OST programs. And the negative attitude towards the program and this drug user registration really affects the employment and parental rights and so on. In this region, I think OST monitoring is one of the most popular topics in relation to the barriers we've mentioned before. The EHRA has supported the studies on the methodology of assessment of satisfaction of clients with the OST programs. And in this methodology, they combined the assessment of satisfaction with the program and the quality of life based on the WHO methodology. This study was conducted in Kiev, Kiev Oblast, in Georgia, Montenegro, Estonia, and Belarus. Kazakhstan has worked a lot on monitoring programs. They have problems with OST. In Georgia, they have a lot of experience in Moldova, Tajikistan, Kyrgyzstan. So that's not an exhaustive list, but these are just the most recent studies we have supported. Yes, and this slide repeats the previous and the main problems, and they confirm. And a couple of years ago, we made a journal on the OST with the evidence provided by the clients of the programs, and it provides some history of the programs, the drugs used, and so on. So it's interesting for the activists, for users, and so on. So this is the context. Now I'm going to give the floor to our colleagues, to the people who conducted the community-led monitoring. And OST is a popular topic because, on the one hand, the OST program is life-saving, and second, because this program is very much covered with myths, and it is provided only, it's very medical, it's provided by the state, and the community is not much involved in that. So probably that's why it's a popular topic. And let's start with our colleague from Kazakhstan. Kazakhstan is fighting now to preserve their program. And she represents the forum of people who use drugs in Kazakhstan. So tell us what you did to improve the quality of the program, to save it, and how successful has it been. Yes, thank you, Maria. We have also have two Natalias here, so they can add something if they can. So hello to everyone. And talking about the most recent news, if you know, maybe we now have active opposition against moving the program to budget funding, and against public procurement and so on. So the most recent news is that we now have a working group that includes also the opposition. And now the information about the positive, that there was sort of request to prepare information about positive experience of OST and submit it to the Minister of Health, and the opposition, they also have sent some letters of their own. So some members of the working groups have sent their positive assessment of this therapy, and we are just waiting what happens, and we're a bit anxious about that. We have very interesting experience because in 15 years of implementation of the OST programs in the country, we still don't have the continuous access to methadone. In case of we just have hospitalization, people have to come daily, and that's of course a big problem for patients who need care and support, and it really affects implementation of the program by reduction of the quality of life of the patients. And the first, well, in the history of the for forum, we had two studies led by the community. The first was sort of poll or survey, if you wish, and it was a part of the campaign called Fight Virus, Not People. And our target was to draw the attention of medical and social services and the general public to the problem of methadone-based treatment, and we tried to collect data for advocacy. And we must say that all our efforts were aimed at developing so-called, well, an algorithm for uninterrupted access to treatment, like providing takeaway drugs for hospitalization. And we also sought to identify their needs and to what extent the services were accessible to the clients of the programs. Also, we prepared letters from the patients to the narcology service in order to ask them to request this uninterrupted access to treatment. So we conducted the first survey in 2020, and it was sort of the first touch to the studies, to this kind of work, this kind of advocacy. The name of the study was uninterrupted impact of uninterrupted access to methadone treatment for the quality of life of clients of OST programs. The idea itself arose as a part of preparation to this program and to this campaign, and the data collected were important for us to develop the mechanism for uninterrupted access to methadone so that people could move inside the country because it was a problem, and also in some other situations, and especially well when we speak about hospitalization. We started the problems. We had 89 persons. We will not go into details here, but it is the first time that we did some, I don't know the word, when we consistently studied and described the problems we had. And it was the first time that we conducted some studies involving our patients. We asked their opinion. So we used the methods of online survey, and there were some problems because not all the participants had mobile phones, and we had to sometimes travel to them, but in general it was a Google based survey. But maybe it was positive because we were able to speak to people, we were able to talk live and discuss things in more detail. But of course, the participants were a bit afraid about taking part because they were afraid of some repercussions from the medical workers doing the OST program. And the positive thing also was that we got in touch with professionals in this area. So, what were our achievements? If we speak about 2020, we were able to identify some key problems and make some proposals about improving the access to methadone for program administrators. Those suggestions, because we decided that it was important to establish this multidisciplinary approach in the teams and identify the quality indicators for work of non-medical specialists, because that's what we were asking about, what people expected from those who work with them. And of course, we recommended regular surveys, but in my opinion, and not just mine, uh, after all this time, not all of our recommendations were accepted. And there was one more thing, that we didn't track some things ourselves because, there was COVID and post-COVID, and there were interruptions in treatment, and we just didn't have the resource to track the implementation of our recommendations because we interact with them mostly by dealing with ad hoc situations. Like something happens and we need to respond to that. We call people, we try to resolve the problems on the sites in the country, but that's good as well. That's a good work. And probably based on the first study, the biggest win that we had was that we had the negotiations with IDPC. And on the website with interruptions, they add the tab of the OST medication was not provided to be able to track such instances and respond to them quickly. So this website, Periboy, about interruptions of treatment is a great tool for us because in Kazakhstan we have very low percentage of people who use drugs. The very low percentage of noting the cases, like notifying about them. So because people are afraid. There we had a big project on street lawyers, but we still have the problem. And this website helps us a lot. And this time we had a big outburst sort of before we sent all those documents. We had a conflict or argument, let's say, with the opposition, and the people, the patients used this tool. So I think that's a big win for us that we were able to achieve that. And in 2023, we conducted community-led monitoring. And we must say that all these projects were part of the activities were a part of the project of the EHRA. And the second study that we have completed recently, that was about impact of OST on the quality of life of the patient. So if we identified the problems, we asked, what is your quality of life? And the methodology was adapted. It was provided by HRA, adapted to the country. Some other countries also use this.
На ваших отчетах спасибо, Молдова, Беларусь, например.
So thank you, Moldova and Belarus, for sharing your reports, because it was a very good chance to gain experience. We also wanted to study how the lack of the medications impact the hospitalization rates, and also we wanted to study the expectations of the program participants and how those were met. The project team conducted this study that included structured interviews. So actually the team had to learn how to conduct such kind of interviews. Unfortunately, we had very small time, very little time for training, and it would have been good to have a workshop with people telling us what CLM is, what it is not, it is not. But still we managed to do it. Thank you, Maria, for your coordination and support. But for the future, I think we need to envisage for some resources, either from third parties or maybe our own resources. But again, we did really well. And also we conducted surveys of asking questions about work organizations with the eyes of the communities, the advantages and disadvantages of in outsourcing the analysis of the survey data or versus doing analyzing them ourselves. We actually involved experts from the OAT Center, from some other partners. So still we face certain challenges, and as I mentioned before, the major challenge was conducting interviews. So I'm not quite sure if I should share the main results or conclusions of the study. I would say that end of 2023, we finalized this study. We developed certain recommendations for handling data on patient health. We identified that peer support was really vital. We also organized a meeting with the mental health center. We went through all those issues. We also discussed hepatitis C testing for the patients. And as I said, we formulated certain recommendations, and some of them were later reflected in certain decisions. So, of course, nobody yet has any resources, any money to fund peer support. We did not do any fundraising yet. It is also important that the treatment protocols are being revised, revisited now, especially the part dealing with mental health. And we drew the attention of our partners to this component, and I do hope that this part will be extended. Some colleagues of mine from the team are also attending this workshop. Maybe they would have something to add. Uh, Thank you, Valentina. Natalia, I can see your hand. Yes, hello, good morning, everyone. Thank you, Valentina, for the presentation. There is only one thing that I wanted to add. After the meeting where we discussed the results of our surveys, we actually stepped into a transitional period, and actually this is the first year then methadone should be provided and funded by this national budget, but unfortunately we have some delays, and the Republican Center has already started handling this problem. Previously, the health code said that even that people using drugs could not receive drugs, narcotic substances, even upon prescription. And now this sentence has been removed from the health code. And the next step, after the medications are procured, would be, according to the doctors, to start piloting the program. This is what they want to start with, and hopefully end of this year or maybe the beginning of 2024, we are going to have very serious changes or shifts. So that's the only thing that I wanted to add. Thank you. Yes, Natalia, what Natalia said also referred to Kazakhstan. Then let's postpone all other questions until discussion. And now our next speaker, Igor, from the All Ukrainian Association of People Living with Dependencies. Please, Igor, share your experience. Actually, Ukraine was the first country where we conducted, we piloted the CLM methodology, and there was a community of researchers collected, and they jointly developed the methodology. And actually, Igor's association called Volna, or the Wave, does a lot in this regard. So Igor mentioned before that they have really a lot of good news. Please share, Igor. Yes, thank you, Maria. Thank you, colleagues. Good day once again, everyone. And regarding the therapy, I want to say that Sergei Filipovich previously wrote us all a message, and I know also, I've heard that some negotiations are going on about adding stimulants to the list of drugs. And I would like to start speaking about the period of time before the Moose project started that we implemented together with EHRA. And that was the time then our association started getting massive complaints about the quality of the medications that were used in OAT. And we tried to have the medication tested by experts, but that was very difficult. It was like sort of semi-legal, because officially, if you want to have a drug sample tested by a lab, you need to find a certified lab in the country, and there are not many. And secondly, there is a special procedure for such testing. So specifically, you need a certain amount of the drug to be tested. So the sample should be of a certain size. I cannot recall specifically, but I think it's 5 to 10 packs or blisters there. So it's a big quality. That's why one individual would have to skip the doses for quite a long to collect the number of pills that could be sent it for testing. So finally, we managed to aggregate the sample, submitted to the lab. And by the way, after that, there were criminal charges initiated against our director because they tried to understand how he managed to collect and move across Ukraine this big dose. And finally, the testing authority, the testing center, actually published the results tests on their site, and the result showed that the medication actually was missing 25% of the active ingredient. So everyone was quite stressed because the medication was purchased through the state procurement mechanism. So if the medication had been withdrawn from the network, then everyone would have been left without the doses. So the laboratory retested the drug and concluded that it did have the sufficient active ingredient, but it was of bad quality because actually the pills crushed very easily. And at that moment, there were about 120 series of the drugs purchased or batches of the drug purchased, different doses, and the entire batch, the entire series were withdrew from the turnover. So we received 170 complaints. So it was a very serious, a big case. And that happened in 2017, 2018. And after that, we started the project supported by EHRA in Kiev and Kiev Oblast. That was the time then private dependence treatment clinics started to appear. They operate under decree number 200, which is a governmental decree regulating the procedures of OAT in Ukraine. And we also have some laws that permit private dependence specialists to give prescriptions for buprenorphine and methadone. So we used a sample of 400 people, 200 individuals that undergo treatment at state-owned clinics or sites, and 200 patients of private sites. And now I can tell you that we received some results that were surprising for all, because we could see a certain trend So we 89 respondents in 2019. So 89 respondents said that they believe that OAT, the substitution therapy, was not 89 people, but 89% of respondents said that OAT was essential for them, was vital for them. So that was a really very high appreciation of the OAT, OST services. Though there was some paradox, some controversy, because people also mentioned poor health status, some adverse impacts that actually reflected the adverse side, adverse quality of life, but at the same time, they really gave very high rating, high evaluation to the quality of substitution therapy programs, because I think the respondents at that time were happy just to have this kind of therapy, to have it existing. And that was really a surprising result. And there was a certain correlation showing that we actually wanted to correlate the quality of life versus OST. And the lowest quality of life and quality of substitution therapy services were mentioned by people who have comorbidity with HIV or some disability, unemployed, etc. That's why final recommendations were to focus more on on those groups. And I remember we had a drug policy forum conducted, and we made a presentation at the forum of our results. People from EHRA also attended, and we also made a lot of presentations of different other forums. We also presented the results specifically for Kiev. By the way, they have the decentralization process going on in the country. That's why every city or town may decide whether they need substitution therapy or not. So we try to make the presentations in different cities, primarily in 8 centers in different cities, to show the benefits of OST. Also, I wanted to share a little bit about CLM, our CLM experience. Following Ehr's example, we did a survey on criminalization, and you can see the results on our website. We surveyed the community members about the types of substances they are using, whether they have ever bribed any law enforcement officers, or whether the law enforcement agencies have ever used force against them, etc. So the results showed that cannabis was the most widespread drug used. 30% of people said they had given bribes. I think the average size of the bribe was about $150. So cannabis was followed by amphetamines and psychedelics. I'm just looking through the results of the study. Yes, could you please focus more on the outcomes rather than results? I mean, long-term outcomes or the impact. Well, regarding the impact, and I cannot tell you what really worked better or worked well, because you know, I'm feeling even now somewhat controversial about the results. So as I was reading through this survey and through the results and conclusions, just through the prism of what followed after that survey, I mean the pandemic, the war, it seems that patients aged 50 plus who are on OAT, they need more attention. And by the way, recently there was a publication on the same topic, and we had discussions on that with the public health center. We have a lot of patients on OST who are aged 50 plus, who are single, who have serious health problems, and they need some particular focus. And this is what we are now discussing. And one of the ideas or recommendations at that time was to conduct regular monitoring. Unfortunately, we could not do it. We did not manage to have separate resources allocated in the frames of the GF funding, GF grant for that kind of monitoring. But we still conducted some sort of an intervention, and we also have regional coordinators in oblasts, and they also provide CLM services, I would say so. And now we do have some resources from the GF, from the Global Fund, to conduct such kind of a survey and monitoring. So we have already developed a questionnaire, including 4 components: access to OST, HIV testing, hepatitis C testing, and harm reduction services. So the idea is to conduct the survey in 2024 in order to get some baseline data from the perspective of the community, the government, the leaders, and then to see, to repeat, to reconduct the survey during the year, and then to see if there are any changes, any shifts from the baseline. And we also had a big survey among women, and it was also published on our website. Sorry for interrupting, Igor, but we are limited in time, and we need to give others also some floor because there is a lot of experience in the region. Yes, but actually all this information is available from the website. Oh, of course. Then please share a link to your website in the chat.
And now I'd like to change the focus a little bit, and I would like to invite Mart to tell us about the Estonian experience. He's representing Estonian network of people who use drugs, and they've got a big study on OST in their last 2 years. And this what's special is that they conducted it also among prison populations.
I will be speaking in English. And first of all, I must apologize. I am only substituting Yelena Antonova, our head of our organization, who is currently, I understand she's involved in the EHRA women's section meeting at the moment. Maybe she can join us later and answer the questions that I may be unable to answer to, because I was Not very much involved in this research. I interviewed a couple of inmates in prisons and did some light language editing, but that was about it. So I asked Lena to answer the questions that Masha sent to us, and I am hereby presenting the answers. The first question was, what method did we choose and in what situation? About the background, 8 years ago in 2016, when the Estonian NGO Lunest was still just an initiative group, our first project was evaluating harm reduction priorities and services. We carried out an assessment within the framework of the Estonian Consortium of Communities Affected by HIV/AIDS, which is our organization, the Association of People Living with AIDS, and the REC LGBT, which is the organization of Russian-speaking LGBT people. Already back then, this work showed a low level of awareness among service clients about the services provided to them, about the rights and the opportunities, and quite a high level of discrimination against service recipients. We paid a little money to rent a room in one of the methadone centers in order to be able to conduct focus group interviews. And the problems that emerged with the quality of substitution therapy services worried our community. Many different studies had already been carried out in the country, and they all gave very beautiful results. So that the question naturally arose, why is the service not at all popular? We were eagerly seeking out opportunities to conduct more comprehensive research on our own, and the announcement of a grant from EHRA could not have come at a better time. So we applied, and we, of course, used the methodology specified by the grant. There was a question about who were our allies and how we prepared for the monitoring. In the beginning, we had very few allies, almost none at the start. A friendly psychologist who often helps us in our work on self-development and team building assisted us in writing the application and provided subsequent support as a consultant. In preparation for monitoring, we sent information about the upcoming study to all partners. In our letter, we asked them to help and support, but we did not receive a single answer. And then we called the heads of the centers and agreed personally. And in personal conversations, we enlisted support and received some agreements. We published information about the upcoming study on the web platforms we use for communication, and sent out sent it out by email. In order to carry out research in prisons, our research team helped us contact the Ministry of the Interior. Prison officials were included in discussions and were consulted with, and online meetings were held to discuss dates and times for interviews in prisons. And all of this was not very easy. The main difficulty was our lack of experience in conducting research. We had to do everything according to our understanding and vision, and it was quite difficult to find researchers. One group of researchers refused to work with us due to a language barrier, which is understandable, as most of our volunteers as well as the clients interviewed were Russian-speaking people with moderate to poor grasp of Estonia. And the group of researchers we had already found helped us with an application to the State Ethics Commission. It took a long time to obtain the permission from the Ethics Commission. We had to answer endless questions from the Commission, give clarifications, explanations, and all of that time wait for the next meeting and the next meeting in order to receive either permission or next batch of questions about how we are going to go about it. To obtain permission to conduct research in prisons, it was necessary to coordinate the process with the Ministry of the Interior and the Prisons Board. and only then submit a separate application to the Ethics Commission. To complete the application, it was necessary to have a complete picture of the research in the prison, from facilities to prison escorts, and motivational packages. In order to understand the whole picture, it was necessary to organize meetings with representatives of all 3 prisons in Estonia. And it turned out that each prison has its own characteristics, its own methods. All this took a lot of time. We managed to agree with the prison services to bring motivational packages to the prison for the interview participants, because the kind of gift cards we were planning to give out, they could not be used in prisons. Prisons have their own shopping system where these don't apply. But overall, it was pretty cool. And as a result, the research in prisons went pretty smoothly, and prison services helped us. The guards even helped us carry the boxes containing motivational packages. We counted on the help of partners from methadone centers and were confident in their help and support. And they weren't entirely sure how easy it would be to conduct research in prisons, but everything turned out the other way around. Interviews in some methadone centers took place in the fields, like in the corridor. Clients had to fill out the forms, scribbling on their knees. One of the centers did not allow us into their territory, but thanks to partners working in the mobile harm reduction service, we were still able to interview the clients of that center. Now the questionnaires. We all worked on adapting them, the whole team, the interviewers, the researchers, editors. At one point, it seemed that everything was clear, but then some minor difficulties began to arise in the process. For example, in prison questionnaires, there was a question about the quality of the room in which a person takes medication. So it was assumed that there is a special room for that. But it turned out that in most prisons, there is no such room. And methadone is given in conditions where the clients have to line up for their dose in the common hallway, or in another prison, medication was handed out by guards to inmates in cells during morning rounds. Or there was a question about satisfaction with the program. And the study revealed that people do not know anything about the replacement therapy program other than that they are given replacement medicine. For example, they did not know that these services should include other services besides distribution of methadone, like peer consultations, meetings with a psychiatrist or a social worker, etc. And so their opinion was formed only on the basis of the fact that they were given methadone. So when we asked them about are they happy with the quality of the program, they said yes, because I get my methadone, and that's like the only parameter that they use to assess the quality. Well, if you talk, what helped us? Basically, the truth itself was what carried us through it. But truth can be, let's say, difficult. We have not yet widely presented the results. We are still in the process. On the one hand, the research took longer time than we presumed, and the final results we received relatively recently. So far, we have Lena has been in a Russian language radio program where she talked about the study, and personally, as I am involved in the work of the Estonian Governmental Prevention Commission's expert working group on drugs, I presented the results to other members of the working group. Well, introduced shortly, explained what we found out, and they seem to be glad to hear that Estonian clients are slightly more satisfied with the quality of the services than those of other countries of the region, where similar studies were also carried out, which is understandable, but sort of misses the point, I guess, that the situation is not good. It's just better than in some other countries. what were the main lessons that we learned from all of this? The first and most important, we gained very important experience in conducting such research. If opportunities arise in the future, we'll be better prepared. And maybe one other thing that that we learned a painful lesson about is reporting of financial resources. We lacked some instructions before starting the project and some support during the process, and because of this there were some difficulties, but happily we overcame them. Now what Lena has says that she thinks what we should recommend to other colleagues based on our experience. First of all, if you have no prior experience in conducting research or the type of research, then you need to ask for support from mentor. Some sort of mentoring arrangement must be made with people, specialists who who have such experience and can show you the ropes, let's say. Before starting work, agree on the forms of financial reporting and proper documentation, because conditions laid out in the grant may differ from what you're used to when working in your own country. So always check that. We would say more time needs to be spent on questionnaires, especially if the country has several languages. I mean, clients of services speak more than one language. Each question needs to be thoroughly worked through, and you need to make sure that the person being interviewed understands it, and understands it the same way that you do. When motivating clients to take part in the study, explain as much as possible how this study being conducted now by the community, how this is different, how this is peculiar. Because a lot of clients have actually had to take part in different studies before, and they tend not to really believe in them, the efficacy or even the need for them. They may not answer an unclear question, or they may answer randomly just to get to get something down and to get a motivational package. So yeah, it's definitely worth paying more attention to potential study participants during the preparation period to weed out those that may not be answering wholeheartedly, let's say. And of course, before filling out the questionnaire, be sure, make sure that the person you're interviewing is sufficiently informed about the program in which he is participating. Like, explain how it's supposed to work, that they're supposed to have access to other services besides methadone distribution, and let them assess the quality based on that information. Make sure that they know what it's supposed to be like before asking to assess. That's all from me for now.
Спасибо большое, Марта. Мы сразу перейдем к
Thank you very much, Mart. And now we are getting to the next speaker immediately. Vitaly has turned on his camera, so I would like to give him the floor. Yes, dear colleagues, thank you. If we speak about the experience of Moldova, I'd like to focus on two studies that we started, one in 2020 and the other just recently. Last year, we conducted a study on OAT programs. Speaking about the study that we conducted first in 2020, we did it to assess the quality of life and satisfaction with the OST programs, and the methodology we chose was based on the WHO guidelines. And the guidelines helped us a lot, and the technical support from EHRA to organize the stages of the study. That's like building the team, choosing the problem, then doing the study, and actually recruiting the team. In this context, we had some problems related to the fact that not all the members of our team were capable of processing data, analyzing and interpreting the data, but it was not a critical problem for us because CLM in itself means community-led monitoring, and it does not limit us, does not prevent us from hiring, recruiting specialists who are sociologists and who could help us in our study.
So what is most important is so that the team from the very beginning and throughout the process would have a similar approach to data collection and understanding of the purpose. So, for instance, during the interpretation phase, we had a challenge in our first survey. We outsourced the analysis to a sociologist who was not part of our community. And the results actually showed that the programs or the OST sites, about 30% of respondents said they were dissatisfied with the sites because there was no access to some gender aspects, so access in summertime, etc. And 70% said they were satisfied. So one of the potential interpretations could be that most of the respondents said they were satisfied. But actually, then we lost the focus on the 30% of respondents who were unhappy with the services. And this is something not to lose, because 30% of dissatisfied clients means that the program is not fully compliant with the service provision standards or not up to the WHO standards in terms of achieving the quality of life. That's why it's very necessary that all the team members would have a general shared understanding of the data collection as well as approaches towards interpretation. In our first survey, we used the methodology based on WHO standards, and another challenge that we had was that we had to pass the test of the ethics committee. And the Committee on Ethics, they have regular sessions, so we had to pre-plan our meeting with the Ethics Committee. So the calendar of our survey had to include a date that would fit the schedule of the committee. And then finally, the methodology was approved by the committee, so we managed to start the actual survey on time. But in our second survey, we missed the date of the committee meeting, committee session, and but that did not hinder the survey. Actually, we started the survey as we were waiting for the approval from the committee, and as Mart previously said, this again says to the fact that we need some shared understanding between the team and between the respondents as well, as to what the survey is about. So what is the target of the survey, whether we want to compare the data to national treatment protocols, international standards, or something else. And again, as Mart previously said, it makes it easier for the team to have such benchmarks, to have some references that helps identifying the gaps, not with the purpose of blaming and shaming, but with the purpose of understanding the context at the national level, at the oblast level, at the national level. And another important aspect was to inform all the parties before we actually start the survey, to tell them that we are about to start a survey, to inform them about the purpose of the survey and about our expectations as to how our potential partners would use the results of the survey. So before any survey, we try to use all available platforms to inform about this survey. Those platforms included vulnerable communities, CCM mechanism platforms where all the parties were present, all the stakeholders were present, and that really helped to include the stakeholders and all other parts, to include all stakeholders into the CLM mechanism. And for instance, even the ministry issued a decree obliging the doctors, the principals of hospitals to allocate the time, the space, and sometimes the premises as well for conducting the survey at these sites, because we had to do the survey during the working hours of the sites. So that's why we needed some space. We needed to use the premises of the site for interviewing for the respondents. Not all the sites have sufficient infrastructure, of course, to be able to provide us with some room or space for conducting the survey, and hence certain difficulties. At most of the sites, we had to interview the respondents outdoors, just on the streets. Also, speaking about partners, as when we made a presentation of this survey before we started the survey, stakeholders from the harm reduction programs showed their support, and they sometimes offered us some spaces of their offices in NGOs where they have a lot of people who are clients of the substitution therapy programs. They come for counseling, for consultations to NGOs, and they allowed us to interview the people on their territory, on their premises. One of the, I want to mention two big umbrella organizations, Positive Initiative and Fair Treatment. So those were the partners who helped us before and during the survey, and also when we presented the results of this survey at the CCM meetings, at some other platforms. And I can see Alla here, Alla Yitsko. So thanks to Alla, we managed to present the results of our survey at a very high level at the Parliament of Moldova, who are now revising the approach of the state towards to meeting the needs of people using drugs. So this includes policies.
И я очень рад тому, что у нас завязалось именно хорошее партнерство в этой области между организациями, между парламентариями, между представителями национальных программ. И эта работа до сих пор, до сегодняшнего времени проводится. Если говорить, в принципе,
if we speak, the final thing, the last thing I wanted to say was that CLM is a cyclic process that we need just to track the results of our advocacy activities and then maybe organize the processes again to check how the programs have been improved in order to ensure the proper quality of life of the communities we represent. Thank you very much, colleagues. I tried to be as brief as possible. I could speak longer, but I will not. Yeah, thank you very much, Vitaly. Thank you for this practical advice for those who want to conduct the studies. And the next I would like to Maria from Montenegro, please.
Hi, hello. I hope you can hear me because our internet in the office is pretty bad. That's why my camera is off. So in 2021 and 22, we actually did a survey that was done among patients of OAT. It was done by the help of EHRA, financial and every other help, actually. It was used to measure patient satisfaction on OAT treatment in Montenegro. So in Montenegro, we have two types of substitution therapy, which is methadone fluid and buprenorphine in pills. So methadone is first introduced in 2005 and buprenorphine is first time introduced in 2015. And around 1,200 people are on OAT in Montenegro. So I don't know if you are in possession of this data. People on OAT in Montenegro have to have a contract with a person from family that is the responsible person for patient's therapy. It's a contract is done with the health center or center that is providing OAT therapy to them, and therapy is administered in certain hours, methadone for the period of 1 hour daily, buprenorphine for the period of 2 hours daily, and some patients take methadone for 7 days, but that's very small amount of, as they say, well-behaved patients who are using the therapy the right way. And other come every 2 or 3 days, but most of them come daily. So when we started doing this survey, we had some issues to start with, because in Montenegro, there actually is a registry for people who use OAT, but the data was not collected as they should on regular basis. So before the start, we had to contact every OAT center for data for the past few years, so we can get the idea on how many people are on OAT in the moment of speaking and before. So based on that obtained data, we have determined visitation days to specific centers that are administering therapy. So we did it all according to the methodology that we received, and it's testing every second or every third person that is on therapy. And of course, questionnaires were anonymously completed accordingly. And we had 300 patients in the survey, but the 299 were valid. So the survey was consisted of 2 parts. First part was doing the in-depth interviews with 4 people from mental health centers who are providing OAT, so 4 service providers and 9 OAT patients. After that, we did a focus group with people from a community of people who are using OAT and using drugs to go through questionnaire and have their inputs on the questionnaire itself. Then we had to go training for people who will work on a survey. All the data was collected via tablet, so we were physically present in every OAT site for multiple times until we completed the number of people. We had issues regarding ethical committee and their approval, in a way that we have a few institutions that have their ethical committee, but they are not collecting themselves in regular ways. So we had NGO Juventus had to make their own committee and obtain their approval. Committee was consisted of legal advisor, a person who is epidemiologist from Institute of Public Health of Montenegro. We have a psychiatrist from a psychiatry clinic from Clinical Center of Montenegro, and also people from the community. After obtaining the approval of ethical committee, we have collected the data from 300 people, so 299 questionnaires were valid. And when we analyzed the data, we actually got some very useful ones. So I don't know if you're interested in I can read some of the data and recommendations that we have, but I think the most useful part was we presented research results to OAT service providers, and we got some great feedback from them, and actually were able to add some recommendations even from them regarding staff, regarding quality of work, quality of places that they work at, etc. And the good thing that the Ministry of Health actually was present at these meetings. And after those meetings, they did a mapping of all OAT sites through Montenegro and started collecting data as they should from the start from all OAT sites. So I have to say that we have very good cooperation with Ministry of Health regarding this matter. And based on the data we can obtain now from Ministry of Health, we are planning and hoping that in the future we can do this research once again, just to see the differences in a period of maybe 4 or 5 years, and if the recommendations that were given are somebody did something with them or not. So I don't know if if I'm supposed to read some data that we got from the research, or maybe just wait for the questions.
Спасибо, Мария. Я думаю, давайте мы дадим слово сейчас.
Thank you so much, Maria. I think we'd better give the floor to Zaza from Georgia now. And when we will start the Q&A session, because I could see in the chance that Paula also wanted to present their experience, but Zaza will go first. And one more thing I wanted to say, that it seems that EHRA is supporting or CLM surveys in the region. I hope that we're not the only ones who are supporting the CLM surveys, and I do hope that some countries support them as well. The floor is yours, Zaza. Thank you, Maria. Hello once again. In Georgia, we also conducted 2 surveys, 2 big surveys. We surveyed about 700 beneficiaries in Western Georgia in 6 towns, and we surveyed the daily patients, and these surveys was somewhat different from previous surveys, and it better reflects the needs, the opinions of the beneficiaries. And the analysis of this survey actually reflects the evaluation of the programs by the beneficiaries, and the data were used to develop practical recommendations to improve the quality of services. And these recommendations actually go to decision makers and service providers. The methodology of this specific survey was different from the methodologies of previous surveys, because the beneficiaries had a chance to directly describe their problems and needs, because that was not a question and answer method, but it was a method of diaries. The beneficiaries wrote diaries sharing their subjective perception of the substitution therapy and its results, its advantages and disadvantages for the beneficiaries. And that allowed us to make really practical recommendations for improvements. We used the qualitative method of the survey. As I mentioned before, the beneficiaries filled in certain diaries, and this is the methodology of targeted sampling. And depending on the purpose and the methodology, we tried to collect the data about the status of the beneficiaries, the location, the time within the program, and all these parameters were considered to build this sample. And the sample participants then had to fill in the diaries describing what they have to go through to receive the doses, to describe their access to the services, and generally describe the pros and cons of the substitution therapy. And for instance, we conducted this survey in the Kutaisi branch of the substitution program. I want to briefly describe the overall structure of the program provided in Kutaisi. The Kutaisi site serves 1,500 beneficiaries. These are people living in Kutaisi itself and in adjacent settlements and villages. Some have to travel 100 kilometers to get to Kutaisi to receive a dose. And this is the distance that many have to travel daily. And this is a program that is funded by the state, so the beneficiaries receive free of charge methadone and buprenorphine with naloxone. And in some locations, they only provide buprenorphine with naloxone.
So why I'm speaking about this? This means that daily a site has to serve up to 1,500 people, and there are only 3 doctors, 2 social workers, and 1 psychologist to work with them all. And these numbers show you clearly that the problems are serious. The beneficiaries cannot receive proper services. The regional coverage is not good because, well, you understand there are long lines at the sites. Everyone's nervous. There's some arguments with the security guards. Doctors are nervous. You cannot talk to them properly because they have to serve 1,500 people in just 5 hours. You understand that's not an easy task, and the OST becomes not what it's supposed to be. It's just discharging the drugs to people. And all the other services, the social services, taking special care of patients, supporting them, well, it just becomes less relevant. And the preparation to the study well involved first development of an instruction to keep the diary of the patient. We got we agreed on the form of consent for participation in the project. We identified the problems, of course, because it was difficult to select the participants, and it was difficult to find the female beneficiaries who receive OST because there is a very high level of stigma, and we had to provide clear explanations so that they could understand it was totally anonymous. We used coding, no names, no surnames, so that they could be sure that we would not compromise their data, so that there are no personally identifiable data. But despite these problems, we were able to recruit 10 persons who completed those diaries for 2 weeks. And it was a very emotional material. Actually, when you read those diaries, you sort of feel what those people feel, how they live, what problems they encounter while receiving OST. It would be really good to give this diaries to read to all the decision makers to get some understanding of all those problems that people have. But unfortunately, we cannot ensure that, but it would have been so good. And we conducted a training for these people to engage them in our study, and the participants trained on how they need to complete those diaries. There were different controversial situations in the course of the study. There were various problems with funding because the exchange rate fluctuated, and we were unable to conduct some of the activities we had planned. For example, we could not present the results of the study, we initially intended to have a big presentation, to have a big event, but unfortunately, well, after we received the money, there was no point already in conducting the study. Conclusions and recommendations of the study. Well, we familiarized our friendly specialists, and we had a final meeting in Kutaisi, where we have representatives of the local authorities and the OST sites and the NGOs working in this area. And the discussion also involved activists of the community and the beneficiaries of the OST programs. In the course of discussions, it was underscored that it is important to follow the recommendations, and representatives of OST agreed to the need to change something in the OST programs, and we also intended to discuss the results at the CCM meeting to let the decision makers learn more about that. But after the end of the study, there was no CCM meetings, and thus we could not present our results there. But yet recently, a CCM meeting took place, and we were able to present it there together with the recommendations. And on the one hand, it was good that in this time, while we were completing after we completed the study, the CCM happened, and some things happened when we were waiting for some improvement in regulations. We had hopes that some regulations would change to the better, but at the same time, the Minister of Health published an order totally prohibiting the takeaway drug use in OST. And that meant that all the illusions that we could, so that even the people who were employed, and sometimes they need to go to a business trip, it was forbidden for them also to get the OST medications. And it was a big problem for them, and it became a choice for them: either they leave their job, or they stop taking OST, because they have their own businesses, they need to travel all the time. So they work either in touristic business or in logistics, and so they have to bring the tourists to different places, and so for them it is very important to be able to travel. And if it takes a few days, they need a stock for these several days and to continue work. But the order of the minister has stopped it all, and that was a problem. So this order concerned not just people who were employed, but also people with disabilities. The first category, people with disabilities, if they don't have in the diagnosis that they cannot move independently, they must daily go to the sites. But you understand that if the person can walk to go to the toilet, That's it, yes, but they cannot go to the site. And sometimes they need to travel from one city to another. You understand how much of a pain it is for them, for people with disabilities, so especially considering that the sites basically have no adaptation for them. Thank you very much, Zaza. I think the things Zaza has been speaking about are actually applicable for all of us. This is relevant because sites are not adapted for the people with children or people with disabilities. And very often in bad weather, when people, as Zaza said, that there are 1,500 of them, the premises cannot have 1,500 people inside, and so they wait in the line outside and wait under rain or snow and get their therapy from some grilled window. So it's not human, really. And Zaza has said that despite the recommendations, despite the CLM, sometimes a decision of one person, in this case the Minister of Health, can change everything to the worst, despite all the advocacy efforts. But if it were not for the community and those studies, we would see no changes at all. So, however disappointing it is, we still need to do this job, and I hope that it will not be just the EHRA that will be supporting these studies in the region. And we don't have a lot of time, really, and I will mention the topic of the next webinar, and then we can switch to the questions, and Paula can tell about their experience. At the next webinar, well, you know, GEF has allocated money for the CLM, and according to the most recent data, the money has been provided to 3 countries of the region: Ukraine, Kazakhstan, and Moldova. And during the next webinar, we would like to discuss who receives this money, who are the beneficiaries, what plans the countries have to implement those activities. The dates of the webinars are still unknown, but keep track of our bulletins. Also, you wanted to add something? No, well, that's it. I just wanted to add one more thing, that after presentation of these recommendations at the CCM, I had this strong speech, and I actually asked the Deputy Minister of Health, asked her, what was the purpose of this order? Why was it made? Why are you violating all the rights of the people, the right to work, the right to have leisure, the right to get to keep dignity when receiving treatment? What's the purpose of that? And the answer was very surprising from this deputy minister. We have information that there can be the drugs can be diverted to black market. How can a person with disability receiving their dose, how can they divert the dose to the black market, or if they traveled? So that was such a stupid answer, and I was totally disappointed by such an answer. But we'll continue our advocacy work, and we'll be doing this work a lot, because that's violation of all the patients' rights or rights of the people, of the citizens of the country. Thank you, Zaza. And now, Paula, please.
Hello, you hear me? Yeah,
Yes.
I'll be speaking in English because I have to have, apologies for being late because I thought it'd be the same as in Ireland, the time was, it wasn't. My name is Paula Kearney. If I'm speaking too fast, someone let me know. I'm from Dublin in Ireland, and I'd be part of a group called Service Users' Rights in Action. We're a group that came together in 2009, and we've been when there was issues around housing conditions and all, what Community Action Now, which would be a community development organisation in Ireland, they were doing a bit of work on the south side of Dublin on the conditions that people were living in. And it was coming up about how long people were being left on methadone without any care plans, without, talking to people who had been on methadone for 30 years in some cases and had never had a care plan, never knew what a care plan was. So a group of us came together that would be people who were using services, drug treatment services, people who had used drug treatment services, and doctors who work in the addiction field. And we found that a lot of the practices within the OST services were direct violations of people's human rights. And a lot, so we've carried out 4 rounds of community-led research. And what the main issues that were coming up was around how degrading people felt, particularly in cases where they had to have someone stand in a room with them while they urinated. And particularly when you consider that for a lot of people who do use drugs problematically, it comes from childhood trauma and in many cases, childhood sexual abuse. So here they are being asked yet again to stand in a room with someone while they had to pull down their underwear and urinate. So that was one of the main issues for us. But as well, some of the issues were around people hadn't got a care plan. They had been on methadone for years. Their health was deteriorating in many cases. And none of that was being looked on. It was just about the methadone treatment. And for many of the people that we'd be talking to, they wouldn't have a GP. So they wouldn't have another doctor who'd be taking care of them issues. So we were fighting to get care plans put into everyone's everyday sort of treatment. And as well as that, around alternatives to methadone, because in Ireland, we have got methadone and we had got Suboxone, we still have, but now we also have Buvidal. So, but yeah, even in the latest round of research, we found that 87% of people that were interviewed have never been offered an alternative to methadone. So, as I said, we have carried out 4 rounds of research, but we always prided ourselves on making sure that the research was community-led, that the questions that were being asked by the people who are closest to the issue, that were being asked by the people who are experiencing these issues on a day-to-day basis. So on our 3rd round of research, we had the Irish Human Rights and Equality Commission had begun to start to work with us. And in Ireland, we have something called I'm going blank. Give me 2 seconds. I'm not going blank here. But the public sector duty, which I'm sure, don't know whether other countries have it in their legislation. In Ireland, we have a thing called public sector duty, where services who work directly with people have to adhere to human rights equality practices, and they have to have a policy around that. So that was, because that had been brought in Ireland, we were able to use that as a tool to engage service users, but also to engage the services themselves. So the Human Rights and Equality Commission, based on this 3rd round of treatment we did, called an equality review in Ireland. And through that, the practice of supervised urine sampling has stopped. But there were many other issues within that, like their action plan had said that they would run focus groups with service users. They'd inform service users of their rights. They'd ask service users for their opinion and how they would like the services run. And none of them have come up. So in 2023, the organisation that I work with, Inner City Organisation Network, we applied to IREC, which is the Irish Human Rights and Equality Commission, for funding we did under the public sector duty grants, because they do grants every year. So we done a 4th round of peer-led monitoring. And I think a lot of people were talking there, and I was listening about the importance of peer-led monitoring and the importance of having people who are experiencing the issues. But similarly to a lot of people that we're talking earlier, unfortunately, our research had to be carried out in the streets. And although we were being funded, everyone that's involved in that group is, for the most part, volunteering. So it was important that we had somewhere safe to talk to people. So as much as we were funded, we obviously had to pay people to go out and do the research and all that, but we had to make sure that we didn't show that there was some sort of incentive for people who use drugs. I know it was only €5, but it was something that you could go in if you wanted to go in for coffee and have a talk or whatever, that there was an incentive for them, because we find that a lot of times people who use drugs are expected to constantly give their story and not be valued. And even though it's just a small token, it's the importance of that. A methodology that we used was of a quantitative and a qualitative method. So it was important to get the numbers of people who are attending services, the demographics that they came from, the gender breakdown of people. And I'm sure with many of you, for a lot of times, the gender breakdown was always more men than women. And that does come into the stigma that women face when they do enter services. You know, because particularly when it's a mother who wants to attend a service here in Ireland, once they're registered as a methadone user, they're also registered with TUSLA and all. You know, if there's any issues, the child protection services and all. So there's a lot of fear based off the stigma that people who use drugs face. So it was important that we, sorry, I'm just going blank there. Excuse me, my kids at home and they keep walking in, so I have to keep throwing them out. Yes, so the gender breakdown and all we were looking at, and as I was saying, like, it was mostly women. But we had a lot of issues because of we had to sit on the streets with people. And I think services in particular need to actually welcome, you know, when there's organizations or groups who want to do research, they need to welcome and provide spaces to provide the people that are attending the services to have that voice. So that Service Users' Rights in Action have always sort of fought to have them voices of the most marginalised in their communities at the forefront. And this round of research was a collaborative piece. That was the piece that ICON done, funded by the Human Rights and Equality Commission. And alongside that was I think I put the two reports in the thing. The Trapped in Treatment was the ICON-based one, but there was other drug and alcohol task force in Ireland as well that got service users and people who use drugs to carry out peer-led research. So we ended up with, I think it was 368 respondents. So it was a great piece of research. And we were lucky enough that we had got the Human Rights Commission, because they provided us a space to stand up, present that research, so that the people who had been there doing it did feel valued. The people whose voices, all stakeholders were invited. The people from the HSE, that's where the monitoring was of HSE drug treatment services. And the people who use drugs were there. The people in drug treatment services were there. But as I was saying earlier about the action plan from the HSE and the need to actually include people's voices, the sad part, like in the statistics, were that 88% of the people who were asked in the surveys were asked, had they ever been asked their opinion on how treatment services were run. 88% of them said no, that they've never ever been asked. And of the ones who did say that they were asked, it was community-based organisations who asked them about how they felt the service should be run. And it was community-based organisations who were included. I know we're in a bit of a hurry, so I think you were saying there will be question and answers. But as I was saying, the Service Users' Rights in Action, we do ensure that everything we do is run by the service users. And we're not a funded organisation, but we are an organisation that's committed to ensuring that people who use drugs are treated with dignity and respect. And I think it's great to have platforms like this to hear so much work being done. So it's really important that we do continue this work. Thank you.
Пола, спасибо большое. Спасибо за то, что наш вебинар заканчивается на позитивных.
Thank you so much, and thank you for noticing the positive change that you mentioned, you managed to achieve through CLM. Also, it's very important that, as you mentioned, you got support from institutions that deal with human rights, patients' rights, and I think that's a great idea for our region as well that we need to try and implement. And another aspect that you mentioned, that it's very important that the questions are also formulated by people from the communities, because they know better what to ask, how to formulate the right questions. Thank you everyone for participation. Unfortunately, we don't have time left for Q&A and discussion, but you have a lot of links in the chat. You can share links to what you believe you want to share with colleagues, or you can drop your contacts in the chat. And please keep a close eye on our schedule of oncoming events. Our next workshop is going to be dedicated to the mechanism or money allocation for CLM by the Global Fund in the countries of the region. And it will be interesting to know how we manage to get this line of funding and what we do in terms of implementation. Have a good day, everyone, and goodbye. Thank you. Thank you. Goodbye. Thank you, everyone. Goodbye. It was great to attend. Thank you.